Before we dive into kind of from now until the end of the semester, we're going to be covering different types of psychotherapy approaches. And I wanted to kind of give you a timeline to kind of help contextualize these different approaches, because we'll be jumping around a little bit. So, as you well know, Freud is the name associated with psychodynamic therapy, which he termed psychoanalysis. And he developed this way back in the 1890s. And this, as you might recall from the history chapter, we didn't really touch on this too much because this development was a little bit separate from kind of what we call the modern history of clinical psychology. However, from the 1890s all the way up until the 1950s, psychoanalysis or psychodynamic therapy was really the only type of therapy. We then got Carl Rogers, who introduced us to humanistic therapy, which we'll discuss in another video. Around the same time as Carl Rogers, we have B.F. Skinner, who introduced behaviorism, and this is what we'll focus on next week. And then behaviorism was then kind of expanded upon and turned into cognitive therapy, introduced by Beck in the 1960s. However, then we get into kind of what is now called the third wave approaches to psychotherapy. So in another video today, we will be talking about motivational interviewing, which is kind of a development that came from humanistic therapy. And then in the last week of the course, we'll be discussing dialectical behavioral therapy, or DBT, and acceptance and commitment therapy, or ACT, which are very popular third wave therapies that really incorporate a lot of elements from humanistic, cognitive, and behavioral, and kind of integrate them together. So we'll be returning to this timeline because I think it's helpful to keep in mind kind of where things are at now versus where they started. And today when we're talking about psychoanalysis, it'll be a bit more about like kind of the historical approach of psychotherapy. So as I noted, psychodynamic therapy was basically the only type of psychotherapy until the 1950s. So it didn't really have much competition. And the other therapies that developed, so humanistic, behavioral, cognitive, they were kind of developed as reactions against psychodynamic therapy and against the theoretical basis for psychodynamic therapy. And so as of now, many of the original psychodynamic theories have been abandoned, or they've kind of evolved to kind of fit more with psychological theories that are common now. However, psychoanalysis is still practiced. It's not the mainstream approach to psychotherapy. And in fact, I would say that most graduate programs in clinical psychology don't really teach psychoanalysis as it was kind of historically practiced. However, there are like separate kind of psychoanalysis programs that still exist. It's particularly popular in New York and in Europe for some reason. But most clinical psychology programs have kind of focused now more on humanistic, cognitive behavioral, and maybe some modern types of psychodynamic therapy. So psychodynamic psychotherapy was originally based on the work of Freud, and he termed it psychoanalysis. And this has been called different things at different times. So we have psychoanalytic psychotherapy, neo-Freudian therapy, psychodynamic psychotherapy, and they're all kind of referring to the same broad kind of umbrella of types of psychotherapies. And we're going to talk about what that means today. So when we're talking about psychotherapy, it's really helpful to understand what some of the assumptions are related to the theoretical background of that psychotherapy. And in psychodynamic psychotherapy, there are some basic assumptions about human nature. So Freud believed that the essence of human nature is to be destructive, and that the human instinct is to be selfish, indulgent, aggressive, animalistic, and that we kind of need to keep that internal instinct in check by really bringing awareness to it and developing strategies to control that. And so overall, the goal of psychodynamic psychotherapy is to make the unconscious conscious. And so psychologists often use the word insight, and this kind of refers to looking inside oneself and noticing these unconscious processes that have been previously unseen. So bringing awareness to psychological phenomena. And so the goal of these therapies are to increase awareness of these unconscious processes so that they can be controlled deliberately rather than letting them control the individual. So this idea that these unconscious drives are bad, that we are kind of animalistic and selfish if we just let our unconscious desires run wild. And so we need to be aware of them so that we can control them. And so within this theory, they believe that the unconscious exerts powerful influence on our lives, kind of on a day-to-day basis, on a moment-to-moment basis, and that these unconscious processes underlie kind of all forms of psychopathology. So whether it's depression or anxiety or a trauma response, that the way that those symptoms are manifesting are kind of like reflective of unconscious processes. And so Freud and others kind of developed various methods for how can we access the unconscious. So, it's unconscious, so we're unaware of it. So how do we bring awareness to these processes? You may recognize a lot of these from kind of like popular culture and media. I think a lot of times the stereotype of a therapist is a psychodynamic therapist, which is a little bit ironic because nowadays there are not very many psychodynamic therapists. But we'll talk about some of the different ways that psychodynamic therapists attempt to access the unconscious. So free association, this is kind of that stereotype of the client like laying on the couch while the therapist takes notes. And they're just letting the client say whatever comes to mind with no censorship. The therapist isn't even really asking questions, just letting the client like run with their mind and just speak whatever comes to mind. And the goal is to have just true spontaneity, just really verbalizing any thoughts that come to the mind. This is different than word association. So this is often another thing that can be portrayed in like popular culture related to psychologists. That is different. That was developed by Carl Jung. And that's where the client is kind of given a word and asked to say the first word that comes to mind related to that word. But free association is different because it's really just like no guidance, no prompts. The client is just speaking their mind. Another way that psychoanalysts might try to access the unconscious is by looking for Freudian slips. These often come up kind of in like jokes or comedy, but essentially it's saying that like slips of the tongue can actually reveal unconscious wishes. So making a mistake and saying a word that is different from what you intended, a psychodynamic therapist might say that the word that you actually said kind of has this underlying meaning and that it wasn't a true just like coincidence or accident. So something like calling a current partner by your ex's name, rather than simply saying that it's like a mistake or a memory lapse, a psychodynamic psychotherapist would say like, in this particular situation, you called your partner by your ex's name because of like unconscious drives or unconscious understanding of how they're the same. Or even things like making a wrong turn that results in you being late to a stressful meeting. A psychodynamic therapist might say that it was actually kind of an unconscious intentional thing because you're stressed out about the meeting. And so this is really just making the overall assumption that mistakes and accidents are actually driven by the unconscious thoughts and motivations of the person, and they're not truly just mistakes or coincidences. A third way to access the unconscious is through dreams. And so psychodynamic therapists believe that dreams help to communicate unconscious material by kind of taking these latent content, that means kind of the unconscious part, and turning it into manifest content. So the plot of a dream or the story. And so dream work or dream analysis uses a lot of kind of symbols, kind of assumes that people kind of have these common shared symbolism in their dreams. And then the therapist can then kind of like analyze the symbols to uncover hidden meaning. This interpretation, of course, is like inferential rather than factual. So the therapist is saying like, based on the symbols in your dreams, like this is a likely pattern that I'm seeing, and they're not saying like this is literally true. But it's this idea that the story of the dream can kind of like symbolize or represent underlying patterns in the person's real life in their unconscious. So Freud believed that dreams were like the number one, like that would be his top choice to access the unconscious mind. But more modern psychodynamic therapists kind of just see it as like one of many avenues. Another way that a psychodynamic therapist might try to access the unconscious is by looking to see if the client has resistance. And so this is kind of like the anxiety or avoidance of certain topic areas or certain things related to the unconscious thoughts and feelings. So maybe the client's like really avoiding a certain topic by like refusing to talk about it, or they really just want to talk about other things, or they miss an appointment. So a psychodynamic therapist might see a missed appointment not as being something just because the client's too busy, but because they specifically like do not want to discuss what was planned for that session. And so it's this idea that people tend to create distractions or obstacles that might get in the way of exploring these thoughts and feelings. Lastly, we have defense mechanisms, which is arguably one of the bigger contributions of psychodynamic therapy to modern psychotherapy overall. So people still talk about defense mechanisms. They maybe conceptualize them a little bit differently, but this is something that Freud developed and has definitely had a big impact in how we think about how people react to things. And so a defense mechanism is thought to come about from the three structural components of the mind. So Freud developed his own kind of structure of the mind that had the id, the superego, and the ego. And so the id is that kind of animalistic instinct. It's very like pleasure seeking, it's selfish. It's thought to be kind of like this biological kind of like primal drive. And then the superego is kind of like the idealized version of the self that's like moral, that maybe feels guilt and shame when things are not going morally, follows rules of society. And then we have the ego that's really trying to just constantly compromise between this id and the superego. And so within Freud's model, he kind of believed that there's like this constant battle between the id and the superego, where the id is saying like, I want to do this now. It's very impulsive. The superego is saying it's not right to do that. It's coming from a more moral or social perspective. And then the ego is saying like, let's figure out how to compromise. And so this relates to defense mechanisms because it's kind of how people respond to negative impulses. So when you have the anxious impulse to do something and then there's a part of you that stops you from doing it, you're likely going to use one of these defense mechanisms when you're trying to make that compromise. So some examples. Displacement would be redirecting a negative impulse in a more socially acceptable way while still lashing out. This could be like screaming into your pillow instead of screaming at your partner. We have repression, which is when people are exposed to the negative impulse, they kind of attempt to just act like it never happened. So this is really just ignoring it or repressing it. Sublimation occurs when someone redirects a negative impulse into a positive behavior. So when somebody decides to go for a run or go work on schoolwork a bunch instead of dealing with their anxious feelings more directly. We might have projection, which is when a person has this negative impulse. They maybe focus on how other people have that negative impulse more so than themselves. So if somebody's feeling kind of anxious while they're driving, they might be like mad at all the other drivers on the road rather than noticing kind of their own feelings about driving. And then we have reaction formation. So this is when a person has this negative impulse and they kind of attempt to do the exact opposite, a positive response in order to make up for having that impulse. So I like to think of when people are kind of like telling with kindness. So you have like someone dislikes somebody, but then they treat them kind of like extra nice or like superficially nice to kind of make up for that negative impulse. Another thing that psychodynamic approaches brought us is this idea of transference. And this is generally considered one of the most important components of psychodynamic approaches that people still do discuss today. And this is the idea that people might transfer their feelings and expectations, their assumptions, kind of their general approach to social relationships they learned at an early age to their therapists. So clients are kind of seeing their therapist as a person and making assumptions about how their therapist is going to interpret them and how they're going to treat their parents. So clients might, for example, apply their negative feelings towards their parents, towards their therapist, or it could be early romantic relationships as well. And so the idea is that the main role of the therapist kind of helps bring interpretation to this process of transference to help draw the client's attention to the process. So again, making the unconscious conscious. And so an important component of this is that within psychodynamic therapy, the psychotherapist is seen as kind of this blank screen. What that means is that the therapist attempts to be as neutral as possible to then see how the client is projecting kind of or transferring their experiences with early relationships onto the therapist. So a similar theory is how the TAT test, if you remember during the chapter on personality assessments, how you're shown like a neutral picture and any kind of interpretation from the client is coming from the client themselves because the picture is intended to be kind of a neutral image. And so this is very much the same way where the therapist is seen as a neutral blank screen and anything that the client kind of feels about the relationship is coming from this idea of transference. We also have the flip side. So countertransference refers to when the therapist might transfer their own experiences onto the client. So we can have it go both directions. So just to take a little sidestep tangent here, I think it's helpful to think about psychodynamic therapy. So this idea of drawing out the unconscious, making it conscious, and thinking about how the critics see that. So some might say that psychodynamic therapy has the potential to be harmful. So I want you to think about, so let's say you have a patient coming in, they're feeling really depressed, they're feeling pretty alienated from society, so like not really connected to people, and they're feeling really confused about who they are, what they're doing in life. What do you think might happen when a therapist tries to kind of analyze this unconscious? So maybe pause for a moment, kind of just think, what do you think could happen here? And so a couple of examples of this. So back in the 1980s and 90s, there was kind of this whole wave of psychoanalysts kind of uncovering the repressed memories of child abuse. And I want to note, so, it's common to have trauma responses that do affect memory. Memory and trauma are closely linked together and can have like a very complicated relationship. But in this particular kind of wave of psychoanalysis, there were a lot of kind of these repressed memories of child abuse kind of being uncovered by therapists that later were found to be untrue. And so in this way, it was potentially harmful because in some ways you could see the therapist kind of drawing out these false memories or suggesting things that made people kind of think they were remembering things that didn't happen. Another example is a kind of very controversial diagnosis is dissociative identity disorder, which is also called multiple personality disorder. And a psychodynamic approach is kind of inherent to the definition of this disorder, because it's this idea that we kind of have multiple personas inside of us. But some people say that DID is actually kind of created by therapists, that people don't typically develop this on their own, that it's kind of the therapist analyzing a person's unconscious and then suggesting that they have these kind of alter personalities within them. Again, this is a controversial area. Some people believe that the diagnosis exists beyond that, but just kind of wanted to add this side note because it's helpful to think about where psychodynamic therapy can go wrong. And so a helpful word here is the word iatrogenic, it just refers to when a doctor or therapist causes a disorder. So this word is also appropriate if a surgeon makes a mistake during a surgery and causes the person to have kind of an additional injury. That would be iatrogenic because it was caused by a medical professional. And so this word is appropriate here because we can think about, so if somebody plants a false memory, unintentionally potentially, but let's say they're doing analysis, they suggest that somebody experienced something that they didn't experience. This would be considered iatrogenic. And I think it's helpful to think about the assumptions of psychodynamic therapy and why this is a particular risk with this approach. So in psychodynamic therapy, as I mentioned, we're assuming that people have these underlying motives that are bad, that people are inherently selfish, animalistic, aggressive. And we're assuming that people have these unconscious motives that need to be analyzed by a trained therapist. So the therapist in some ways has like power over the client because they have the tools for analysis that the client does not have. And I want to contrast this with humanistic approach. So I'll be going over the humanistic approach in the next video, but overall, humanistic approach assumes that people have good underlying motives. And it has this assumption that people will kind of have this unconscious potential, but that it's explored together with the therapist in a very client-centered way. So rather than the therapist analyzing the client, it's more like they're working together to help uncover some unconscious potential. So thinking about psychodynamic psychotherapy broadly, it's difficult to gauge the effects of how well it works. In part because it's very difficult to quantify things like the unconscious. It's very difficult to quantify things like insight or self-awareness. And it's also very hard to disprove the theories because they are not necessarily written as like scientific hypotheses that can be tested. We also have the issue of allegiance effects. So what this refers to is the idea that researchers will likely choose to research things that they are interested in. And so what we see is a lot of treatment studies on psychodynamic therapy are being conducted by people who kind of have an inherent bias or preference towards psychodynamic therapy. It's kind of like in a legal case, you have the prosecutors and the defense, and they're going to be looking at evidence in very different ways, even if the evidence is objective. And this is an issue across different types of psychotherapy. It's a particular issue with psychodynamic therapy just because it's a bit more of a niche area these days. However, it's really helpful to know that some individual components of psychodynamic approaches have received quite a bit of empirical support. So this idea that developing insight is helpful for people, focusing on countertransference and transference, these are all associated with having more positive outcomes in psychotherapy. And we can also look at more contemporary forms of psychodynamic therapy. So a lot of the things I've been talking about in this video and that are included in your book chapter are referring more to the historical kind of Freudian approach. But there are modern types of psychodynamic therapy that have kind of evolved beyond that. And so a lot of modern types, they really de-emphasize that kind of biological or sexual unconscious drives. And it really highlights broader interpretations of the unconscious. So in ego psychology, it really focuses on that ego, which is that kind of compromising part of the self, and explores social relationships and how the ego really makes a lot of compromises that are adaptive in promoting healthy social relationships. In object relations therapy, it focuses less on the internal conflict and emphasizes relationships between internalized objects. And objects here refer to important people or ideas in the client's life. And lastly, we have kind of what's referred to as self-psychology, which is a type of therapy that really emphasizes the parents' roles in how a child develops. Another issue related to psychodynamic therapy is that it tends to be very long-term. So in theory, somebody could be in psychoanalysis for years, and there's kind of always different things to uncover and explore. But this is really at odds with a more recent push in psychotherapy towards efficiency. So as we've talked about, insurance companies have a big say in how long someone might see a therapist, as well as there's a bigger push in the field for kind of setting goals that are achievable within like an appropriate timeline. And so in more recent years, brief psychodynamic therapy has become pretty common. These are often fewer than 24 sessions, and they have shown to be successful when problems are mild and more narrowly defined. So getting at that ability to set goals. The focus is more on the present rather than solely on the past, like other forms of psychoanalysis might focus on. And so I'm posting a video example of some kind of more modern style brief psychodynamic therapy, but I want you to look for clues to ideas that came up. So how is the therapist trying to access his unconscious? Are there defense mechanisms that come up? Do you notice any transference or countertransference? Just kind of, as you're watching that video, take a look and see what aspects of the historical approach do you see. And lastly, I'm going to touch on one of the most kind of supported types of psychodynamic therapy, which is referred to as interpersonal therapy for depression. And I'll just say as a kind of a side note, from what I know about IPT, it goes a bit beyond just strictly psychodynamic therapy. So even though it's rooted in it, I think it draws from a lot of other forms of therapy as well. But IPT was originally created to treat depression. It's now used to treat other disorders as well. And it has very focused and limited goals. So its primary goals focus around interpersonal relationships. And it has a lot of empirical support for treating depression. So efficacy studies show that it works quite well for treating depression. And there's some evidence that it can treat other disorders as well, although it was developed to treat depression. So it takes this assumption that depression happens in the context of our social relationships. So depression is not just kind of this internal thing, it manifests in how we engage with other people. And the limited goal, the very specific goal, is to improve relationships, and that will help improve depressive symptoms. And unlike traditional psychoanalysis, it really doesn't focus too much on the intrapsychic structure of the id, the superego, and the ego, and it doesn't really focus on childhood fixations. So it's much more present moment oriented and focused on, really strictly kind of these social relationships. So just an example of what a course of IPT might look like. There's kind of 3 stages to the treatment. So in stage 1, which is just the first couple of sessions, it's really more of assessment. So you're really understanding the client's problem and really trying to categorize it into these 4 categories. So are they experiencing role transitions, role disputes, where their social role doesn't necessarily fit how it should, or if there's like contradictions in a person's social relationships and the role that they're in? If there are interpersonal deficits, and if the person is experiencing any grief. And so these first couple sessions are really just exploring a person's social network and seeing and identifying these areas. The second stage will then be the bulk of the treatment. And this is really using a lot of psychoeducation, which is to teach about, what is the nature of social relationships and the impact it has on depressive symptoms. And then to use psychodynamic techniques to address current emotions that occur within these relationships. So this is really about bringing awareness to the unconscious, bringing awareness to emotions. And then stage 3 is reviewing, changes that have occurred, highlighting the client's ability to maintain these gains on their own, and making plans for relapse prevention. We also have a couple of other modern approaches. So transference-focused therapy is really just going to focus on that process of transference, really just looking at the relationship a person has with the therapist. And then mentalization-based treatments, which mentalization refers to the ability to correctly identify your own feelings and the feeling of other people. So this is really focused on social cognition skills, this idea of kind of being an empath, the ability to be attuned to your own feelings and other people's feelings. And the theory here is that negative experiences in childhood affects one's ability to correctly interpret emotions. And so it's kind of identifying that deficit and then learning how to kind of fix that deficit. And so that is it for the psychodynamic psychotherapy chapter. It's helpful to think kind of big picture when we're going over these theoretical orientations. So really understanding kind of what are the basic assumptions that are made about clients, what are the overall goals of the therapy that go beyond the techniques. And as we continue talking about other approaches to psychotherapy, I'm going to be kind of referring back to these previous ones because it's really helpful to contrast and compare the theoretical orientations.